hopefully that worked. I finally have gotten everything set up here. So thanks for the patience, everybody. And I'm glad to be able to speak with you today. I want to speak, the end goal of today's talk is to discuss screening for psychosis, but I think that screening for psychosis brings up two issues. First, it begs the question what psychosis is, which is a good question to ask because it's a term that has not been really adequately defined, ironically, ever. And knowing what psychosis is actually will help you to better screen for it. There, as you'll see, there are many, I think, shocking deficiencies in this entire area of thought and care. So I will tell you what I think is worthwhile to know, and I think it's, despite the deficiencies in officialdom, I think it's quite possible to effectively screen for psychosis. I think it's definitely a worthwhile activity to do. So starting off with what is psychosis? Psychosis, I will just give some advance warning. I tend to be somewhat of a snarky person, and that is because I actually care quite deeply about people having great chance at having awesome lives. And I think that a lot of stuff that my field does, despite having done many great things, still has done a lot of things that gets in the way of it. And it makes me a little bit crusty. So you've been warned. Psychosis is a term that was coined, it first appeared in medical literature in the year 1843, which, to put into context, was 2 years before Semmelweis in Hungary started saying we ought to wash our hands after we dissect cadavers and before we examine women who have just given birth. So the concept of we ought to wash our hands was not even born in official medical thought when we were bringing up the term psychosis, just to put it into the, the history of knowledge development. And when it was described, it was really never, it was just described as a term for sort of grave impairment of mental functioning. That is a definition which would fail most standards of definition that we have adopted today in any medical specialty for terminology. And in psychiatry especially, we have adopted a reasonable standard of having criteria that can be relatively objectively defined and reliably agreed upon between different observers. Psychosis, however, is still not defined officially in an operational term. If you go, I might be wrong about this, so if anybody has seen this in any DSM or wherever else, please do let me know. But from my reading of DSM, I can find no entry where it says, when we say psychosis, we mean A, B, C, and D. There are many things that you can try to infer what they mean when they say psychosis, and psychosis is the most basic and probably agreed upon definition is the presence of delusions or hallucinations, delusions being unusual beliefs and hallucinations being the perceptions of sensation without the external stimulus of sensation. But I'm coming to that in a second. But I think that a way of defining psychosis or of redefining psychosis in ways that are actually much more sensible and would probably be substantially less stigmatizing, which I think would be a very good definition for any physician in any specialty to use, is to just refer to psychosis as a misperception syndrome, because I'm a person who has thought deeply about psychosis for a long, long time. And I think that psychosis is best understood and probably accurately described as a phenomenon that arises when the thinking parts of the brain are trying to make sense of clusters of misperceptions that are generated by the perceiving parts of the brain. Brain has many parts, it has many systems that do many things, and some of the more basic systems are in fact just collecting information and forming perceptions out of them. And those basic systems can quite easily, it turns out, form misperceptions when there is some sort of systemic influence on that processing machinery. And when systemic influences on that processing machinery are at play, there will be clusters of misperceptions that then thinking part of the brain has to, and that's how it happens, basically. Delusions, technically, this is actually a term that is defined in DSM. They call it fixed false belief not amenable to change. And the common themes, the most common ones are suspicious or paranoid or spiritual or grandiose. I'm going to make sense of those in a second. You can also have delusions about the body, or we have this term in psychiatry called referential, which means that you can look at things, you can look at or perceive things external and think that they are related to you. And it's also quite common or not uncommon in people that are experiencing psychosis to have beliefs that their thoughts are being read or that their thoughts are being inserted from outside. So those are the most common kinds of unusual beliefs, aka delusions, that you can see in states of psychosis. Hallucinations, as I said, are the perception of sensation without the corresponding external stimulus. They can occur in any of the 5 sensory domains. Auditory hallucinations are far and away the most common. There is a constant debate that you can somehow arrive at a truth of diagnosis or a truth of causation by asking a person, is it like inside your head or outside your head? And the literature on that, like trying to locate the location of hallucination, suggests that it's not, I wouldn't spend a whole lot of time on trying to discern whether the person perceives it as external or internal. In other words, I think it's useful to know, but it doesn't really guide decision making very well. So I don't think it's a high return on investment line of questioning. And it is also, the literature seems to be a bit split, because clinically speaking and in many more anecdotally informed articles in literature, it's thought that visual hallucinations should be regarded as a red flag for organic or medical illness as an underlying cause. But other analyses, more objective and empiric, suggest that clinical lore might not be extremely accurate. So suffice to say that they can occur in any modality, and we'll leave it at that for now. Some definitions, or at least, as I said, nobody's officially defined exactly what they mean when they say psychosis. DSM seems to imply that it might also occur with disorganization. Certainly people with hallucinations or delusions will have substantial disorganization in what we infer to be their thinking based upon the ideas that they express in a disorganized fashion in their speech. And that can, the degrees of disorganization can range from just being extremely circumstantial to being tangential, which means that a person never really comes around, they never really circumlocute back to the original point. They just keep going from tangent to tangent to tangent. Or this can have it can be the case that one concept has seemingly no relation to the previous concept. Or there's a phrase in psychiatry that is called word salad, which I think probably is better and more accurately, or be more worthwhile to just call it fluent aphasia. Why I would prefer fluent aphasia as opposed to word salad is because it will cue the clinician and everybody else around to regard this as the neurological problem that I believe psychosis is, rather than the psychiatric or psychological problem that most systems default to assuming. But I've certainly talked to people who've had Wernicke's ischemia, who've had strokes in the area that produces fluent aphasia, and I've talked with people with schizophrenia who have quote unquote word salad. They sound the same to me. So but just as an aside, that's just an example of an extreme form of disorganization. There is also, it's not uncommon in people experiencing psychosis to observe catatonia, which is most commonly a syndrome of extraordinary psychomotor slowing. People with catatonia are typically immobile, slowed to the point of not moving. They can sometimes be posed. You can move their arm or a limb, and they will sort of hold it in space for a while. It's probably in general medical practice pretty rare, but in psychiatry not uncommon. Catatonia, incidentally, is associated with, most commonly catatonia is associated with bipolar disorder. About half of people with catatonia have an underlying mania, and about half of people, and about a quarter of people with catatonia have an underlying schizophrenia, and about a quarter of people with catatonia have an underlying depression. So catatonia, like psychosis, is just a very non-specific symptom that has several different possible underlying causes. And continuing with sort of what is psychosis as a tool to help understand it and to explain it and to screen for it, then we will go to some explanations. The explanation that I like best is explanation that makes a lot of sense, that is easy for clinicians to understand, that is supported empirically, and that also makes a lot of sense for patients and families, is technically called aberrant salience. Salience meaning significance, aberrant meaning that you have this perception of significance that is erroneous. And aberrant salience is sort of based on the brain's need to solve this extraordinary problem, and that is, I call the information mismatch. The part of the brain, generally prefrontal cortex, that gives rise to conscious perception, your sense of self, that whole enterprise is very demanding of resources and can, it is estimated, work with about 50 bits per second of information. Meanwhile, all the nerves in the body are sending information up to the brain at an estimated rate of 11 million bits per second. So it's quite a massive mismatch between incoming information and the ability of conscious awareness to attend to it. So before much of what happens, or much of what the brain is getting from sensory perceptions, is processed in the background outside of conscious awareness. And so the brain does a huge amount of what I call filtering and filtering and rejecting. So as an example, I count, just look at this picture, and you've already known what the picture is about. Within a half a second of seeing it, you discerned automatically, because your brain does this kind of thing for you, that this is a scene where a woman is inviting the person into the office to sit in the chair. But you weren't really aware that there are minimum of 50 or more different elements of information within this scene, and that's because your brain just automatically honed in on the relevant things of a woman with an inviting gesture and pointing to a chair. So these two things highlighted in green seem to be the most relevant of all this cluster of different sensory information. Thank you, brain, for highlighting all that to us. But now imagine a situation where you are misperceiving, your brain is generating clusters of misperceptions about significance. You are generating aberrant salience. So now, instead of just the woman and the chair, you are now getting sensations of significance about the woman and the garbage can and the plant and the clock. What in the world to make of that? So now thinking brain is presented with perceptions of significance that it has not encountered before. And thinking brain needs to create a narrative. So I say, I think this is true. I haven't heard people put it exactly this way, but we as human beings have, I think, our first most important need is for oxygen, and our second most important need is for sense, is for logic. So we have, like, every second of our awareness, we have to have a narrative or a story. We have to have a sense for why we are where we are, how we got to this minute, and because we need to have some sense that we might know what's going to happen next. So creating a narrative of the current situation presumably gives us some ability to reasonably accurately predict what might happen in the next short time, and that will enhance survival. So we're compelled to create a story around everything about us. And so if we're now getting if the brain now thinks we have to make sense of this, well, what stories do make sense of that? And maybe she's giving a message about plants and death and time. So maybe this is a message of urgency and peril. That would be a suspicious, paranoid flavor of things. If the goal of my sense-making apparatus is to protect me, then it makes sense that my sense-making apparatus as a first pass hypothesis generator is going to come up with peril as a thing to rule out. So that explains why suspiciousness and paranoia are probably the most common forms of delusional belief. But we can also, magical connections make a lot of sense as well. Spiritual things, so I can now imagine that I've now gotten new insight into, I can now, this woman controls time and life and resurrection, and I have insight into this. And so magic, supernatural, because it helps you escape the ordinary rules of connection and non-connection, is a way that that sense-making brain can make sense of stuff that ordinarily doesn't fit together. So grandiose, spiritual, religious explanations morph into grandiose delusions, which are the second most common kind of delusional belief you see in psychosis, which is kind of why I don't like the term delusion very much, because it carries with it all this stigma baggage. And really it's just a belief, it's just a hypothesis that makes sense of things that seem like they shouldn't make sense to the person experiencing these misperceptions. And when you're faced with clusters of significance that seem like they shouldn't fit together, and then you come up with an explanation that puts them together, you experience a reduction of tension. And reduction of tension is a reward. It activates the reward system. It's called a negative reinforcement in psychology. But now this makes sense, that is signals a reward. So the next time you're faced with a cluster of misperceptions and you experience that tension, you've had a memory trace attached to a reward that says, oh yeah, there's death happening around me, or, oh yeah, I have supernatural powers. And so this frame that you begin to adopt, you can then start to make sense of other things, and then it becomes a cycle that becomes a belief, which over time can become a stronger belief, and that's how you go. I'm not going to spend more time on this topic, but hallucinations, suffice it to say, can be explained through the aberrant salience hypothesis. There are dozens or perhaps hundreds of little ideas going through your head right now. I understand you're listening to me, but there's also little stuff in the back of your mind that happens all the time. And most of the time we ignore the noise from the part I call the idea generator circuits. But if you have aberrant salience, if the brain is attaching unusual significance to irrelevant things, then there's a reasonable chance that some of those back of mind noise chatter get tagged with significance. And because that's something you don't usually pay attention to, you might perceive that as not being your own. And so you may then interpret that as a voice from outside, thus auditory hallucination. And it's also common, and it's also possible, and it's also shown by functional imaging, that you can have sort of autonomous activation of cortical areas in auditory cortex, for example, that subserve auditory perception. So you can have dysregulated perception machinery at cortical levels of higher level perception. So altogether, psychosis is a misperception syndrome. Happens because the parts of the brain that need to make sense of stuff are now presented with clusters of misperceptions that need sense made out of them. And why does it happen? We know that in a substantial number of people experiencing psychosis, the brain is actually making more dopamine than it probably should compared to people without psychosis. Studies using positron emission tomography, using methods that allow us to measure dopamine synthesis, which is a really cool thing we can do these days, have shown that people who experience psychosis on average are likely to make more dopamine and release more dopamine. And dopamine is critically involved in many of the circuits that are devoted to the recognition of significance and reward. That's why, by the way, why pro-dopamine drugs like amphetamine are useful in ADHD, because they help prime the circuits that are supposed to register when significant things are happening. So overactive dopamine is present in probably the majority of cases of psychosis. However, there are many pathways to the misperception syndrome. We know that there are individuals who seem to have sluggish ability to respond to endogenous glutamate. There are hypoactive NMDA receptors. And also we know that drugs that block those NMDA receptors can cause a psychosis experience. And that PET study stuff that I was talking about earlier has shown that the dopamine, that the overactive dopamine makers are not the same people as the glutamate non-responders. So there are non-overlapping, it seems to be non-overlapping pathways. You can also experience psychosis if your brain is unusually responsive to serotonin. The hallucinogenic drugs like LSD or psilocybin are very strong agonists at the serotonin to a receptor system. And so there's another pathway. So there are many ways that, and inflammation as well. The point being, there are many neurochemical pathways that can lead to clusters of misperceptions. As I said at the beginning, many of those 11 million bits per second of information coming in are raw material that the brain is using to construct perceptions of the outside world. And that requires a lot of computing and a lot of energy and a lot of complexity. And when you have high complexity systems that are supposed to be timed within milliseconds of each other, there's a lot of opportunity for error and thus a lot of opportunity for misperception using a lot of different neurotransmitter systems. Psychosis as well, in the what is psychosis, I call it the most common problem that nobody talks about, because we have, for example, programs in place to try to, sorry about this, we have programs in place to try to reduce teen suicide, to try to address obesity, to try to prevent diabetes that occurs in adolescence. We have programs in place to try to reduce the occurrence of teen births. You've heard about all of these common problems that affect adolescents, and have anybody ever heard of any public awareness programs or public health interventions to try to reduce the occurrence of psychosis? I have not. Yet psychosis in adolescents in cases per 1,000 per year dwarfs these other problems. Thus, the most common problem that nobody talks about. And for those who want the numbers, those are the sources. So, and as again, the brain has a hard work to do, and it can easily generate clusters of misperceptions. Various estimates, 1 in 12, sometimes higher, sometimes lower, but a substantial higher number than most imagine points to the, let's see, about 1 in 12 people, maybe more, will experience some aspect of psychosis during their life. Speaking of screening of psychosis, then that's a nice segue. I think the first thing to talk about, part of why I told you this in the beginning is because being the most common problem that nobody talks about, if you don't talk about anything, if there's not knowledge in the public space, then fear and bias and prejudice and all the stuff, all nasty shit, fills in the space where knowledge should be. And so if you have a vacuum of knowledge, you get you get stigma. So, and when you, and if nobody can explain psychosis in terms other than break with reality, by the way, please don't use the term break with reality. I would suggest that break is a good word to describe fractures, but probably a bad word to describe anything else related to a human being. So, you know, terms like first break, psychotic break, and blah, 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 we can explain the phenomenon more elegantly and more accurately and without the metaphor of damage in that fashion. I was giving a lecture one time at my at a former university. The lecture was about, it was sort of related to my research, and it was related to my research, but one of the aspects, or one of the channels of knowledge about my research was that non-steroidal anti-inflammatory drugs for some people cause psychosis. They can cause hallucinations or paranoia. It is apparently a fact. It's been reported many times. It's not common by any means, but it certainly is a reliable observation. And so there's that. I mentioned that during my lecture, sort of in passing. And at the end of my lecture, a nurse who I'd worked with for a long time came up to me afterwards and said, "My gosh, thank you for telling me, thank you for mentioning this stuff about NSAIDs. I mean, every time I've taken ibuprofen, I hear voices. And I've never told anybody about that. I never knew that, but you know, thanks for mentioning that." And so I think that I tell you this story for a couple of reasons. One, I mean, this person knew forever I was a psychiatrist and knew my personality well enough before the lecture to know that I was a reasonably approachable person, but never thought to approach me with this until she heard that this happens and there's an explanation that makes sense, that's not stigmatizing. So I think that talking about stuff in the open as, yeah, this happens quite a bit, and there are some ways to explain it in ways that are non-stigmatizing and easy to understand, makes people open up in ways that don't happen otherwise. So I think if you want to screen for psychosis, it can just be helpful to know that it's something that that can happen quite easily, it turns out, to human beings, and that it's just like, you know, a bit of a mishap in a very busy brain that indicates that there's something that may be going on that we should look into to try to see what's causing and how it can be fixed. So, and this is where we get now to another point of a bit of a shock. There's not a standardized screening tool, despite this being the most common problem that nobody talks about, despite schizophrenia or psychotic illnesses affecting between 1% and 3% of the population, despite early detection being associated with better outcome, despite schizophrenia associated with a 1 in 2 chance of suicide attempt and a 1 in 10 chance of suicide completion, despite all that stuff, and knowing this for 50 years, we have not yet developed a reliable screening tool for any practice setting, especially primary care. I don't know enough. I do not know enough about the psychometrics of screening tools to comment extensively on this, but from my reading, there are apparently difficulties with how to describe it in ways that are going to be acceptable to a variety of ages and cultures and levels of understanding and acceptability and so forth. And also, I think psychosis being a concept which has, you know, going back to my beginning, with no operational definition in the DSM, and that's a big problem. If we don't have a universally, say, a totally agreed upon definition about what exactly is psychosis, or what would be the central elements of it, or whatever else, I think that's going to be another factor. But there are many things that have been developed, but nothing has been gotten the seal of approval from any of the grand poobah organizations that issue such seals of approval. It's not quite as dire as I am making out here, as I'll show you in a second, but there are some tools just, it's been quite difficult, and there are disclaimers about the tools. It is recommended by people who try to develop tools that we do follow up positive mental health screens that you probably are doing, like PHQ. I mean, there are a variety of screening tools that are for mental health related issues in primary care. So if somebody answers positively on a screen, then that would be an extremely good opportunity to inquire about some psychosis symptoms, because if somebody, for example, is experiencing depression, like first, I think about 20% of depressions actually have psychosis attached to them, and many people that are experiencing psychosis from, say, schizophrenia or from, say, lupus will experience depression as well. So any kind of mental health aberration would be a good opportunity to just gently inquire about some psychosis symptoms. And anytime that you have been aware through history or complaints that suggest declining levels of functioning in social, educational, or occupational spheres, that would be an excellent time to inquire about psychosis. These are what I do. I have found it most useful to just have the attitude of, yeah, this happens quite a bit. I've seen this quite a lot of time. You know, if you are not, if you as a clinician can eliminate your fear or awe or own misunderstandings around it, then you'll become, you know, more matter of fact and able to convey, without betraying your sense of fear, the question. So it helps to be non-fearful and non-judgmental. And I think it's been my experience that the best way to do it is just to ask questions in a normalizing fashion and try to relate it to the symptom that is being discussed at the time. Quite often it can be, let's say depression. Let's say, for example, you've identified a patient through PHQ screening who looks like they might have depression. Then you can simply say, you know, I've noticed that quite a few times when people have depression, they can get to a point where things seem like not quite right, like maybe not quite real. Have you ever had a sense that the things aren't quite real with you? Sometimes it can be to the point that they feel like their thoughts are intense, as if they're not their own. Has that ever happened? Or that thoughts are coming from outside, or that it's like a voice coming from outside. Have you ever had that happen to you? So you can move from the current symptom, anxiety, stress, depression, lack of sleep, and it can become intense enough that unusual things happen like this, or that some people that have experienced X will start to think that people are out to get them, or that the people are monitoring their conversations. Have you noticed that you've become, you know, more suspicious than average lately? So these are ways that you can just tie in any other conversation and simply say, there's a spectrum, and have you gone farther on the spectrum? Have you gone that far on the spectrum where it seems like things are not making sense? Simple as that. There is a organization funded, it seems to be Massachusetts based. I think it's funded partly by the government of Massachusetts, and several organizations within Massachusetts have come together. It's a kind of nice, and to my reading, a bit confusing website, but they have a lot of useful information, and you can go there and read many things. They have come up with what they call the FACS mnemonic. So looking for a functional decline, atypical perceptual experiences, cognitive difficulties, thought disturbances, or speech or behavior that's disorganized. And they have downloadable questions. Personally, I find the questions to be a lot. You could get them if your initial, like, have you ever had unusual experiences, like you've heard sounds that weren't there or something like that, or you can just use this, whatever you're comfortable about, because your comfort in asking is going to be, I think, a very important thing. And also asking questions that make sense is super important. And I think that well, certainly that's the end of my slides. What I will do now is stop that and